Good afternoon, ladies and gentlemen. I really welcome you to the last session of this 27th Conference of Alzheimer Europe. And I'm happy that still people are around, because otherwise you will miss a very interesting session. We will have a roundtable discussion now about the theme of the conference, Care Today, Cure Tomorrow. And we want to identify current and future research priorities. Maybe I introduce myself. I'm Sabine Jansen. I'm the Executive Director of the German Alzheimer Association, and I have the honor to moderate this roundtable discussion. And I have 7 really interesting people around me. And first of all, maybe some background. Alzheimer Europe called for an increase in funding for dementia research several times. For instance, in the Paris Declaration 2006 or on the Glasgow Declaration 2013. And if we look back, it has given a significantly progress in the last 10 years, and a lot of European research initiatives, but we also still complaining a lack especially if we compare with other diseases like cancer or other diseases, if we look to the funding for dementia research. And now coming to the discussion, I first would like to introduce to you Helen Rochford-Brennan. Probably you know her already because she has a lot of active roles in this conference already as a chair and as a presenter. She's a person with dementia, chair of the European Working Group of People with Dementia, and also member of the Irish Working Group. And Helen, I would like to ask you first, what are your expectations concerning research from the perspective of the people who hopefully should benefit from research?
Thank you for having me. As chair of the European Working Group of People with Dementia, and as a person with dementia myself, I would like to highlight the following research priorities. Every person living with dementia and their carer should be offered, if they are willing of course, to be supported and participate in research. Participating in research gives hope to people with dementia and their carers. As we've heard many times during the conference, there is yet no cure for us, so all we have is hope. Not only does it offer hope by being involved in research, but we can add so much value as well. We have the experiential knowledge. The sense of purpose that it offers to a person with dementia is so meaningful, and the research team benefit from the expert of those with the lived experience. And I would also like to add, as you all know, this is a family illness. There is no greater joy that we could give our loved ones than to participate in research. Research should help people with dementia have a good quality of life and also address aspects related to rehabilitation, social support, and palliative care. We talk about care today and cure tomorrow. This is so important. I need something that helps me to live well today, and I need to have hope for a cure tomorrow. The drugs do not work for everybody. In my experience, it was cognitive rehabilitative therapy that gave me the renewed purpose and a method for living well with my dementia. There is a lot of biomedical research being carried out to find a cure or more effective treatment for Alzheimer's disease, which is very positive. However, it should not be forgotten that whilst Alzheimer's disease is the most common cause of dementia, other types of dementia also exist and also deserve attention.
Thank you very much for the statement, Helen. The next person I would like to introduce to you is Lutz Frölich. He is professor of geriatric psychiatry and head of the Department of Geriatric Psychiatry at the Central Institute of Mental Health in Mannheim, Germany, and of the University of Heidelberg. He also is the co-chair of the European Alzheimer Disease Consortium, a network of centers of excellence of academic research for translational Alzheimer's research. Lutz, as a person who works for many, many years in the field of Alzheimer, we know each other for many, many years now. If we speak about patient-related research, that's one of the aims of the Alzheimer Consortium, as I have understood. What do we mean by this? What kind of research has to be done?
Well, being a psychiatrist and a clinician who works with patients actually, and both a clinical researcher, I think it is important that our research is really devoted to the benefits of patients in a more direct way. Of course, every researcher, everyone who works with mice or cell cultures also wants to be for the benefit of the patients ultimately, but to do it this immediately is the task of the physician. So I think we have had two very elegant talks in the previous symposium by Wiesje van der Vleer on the diagnosis and the diagnostic issues and how you have to take a breath above all the advantages that have been achieved on the diagnostic issues. And I think this is one of the greatest achievements in research so far. And now we are trying to sort of get to find out what really is benefiting patients and how you can involve them in that type of research advancement. So I think this is a very good focus of patient benefits in biomedical research. And I think this could be one of the priorities of research, to involve patients in the diagnostic issues and in the diagnostic opportunities and find out what is really good for them. And of course, when I want to add something, I think the search, innovative search of research could be on a blood-based diagnostic test. So this is one of the issues which is currently being investigated, and to find out new markers or new diagnostic opportunities by blood testing would be great also. And as you, Helen, have said before, the research on treatment is really very strong, obviously. Yeah? And there have been so many failures, as Frank Jessen has shown, and how we can improve the ways of doing research, more than to find the magic compound, more the way of doing clinical trials and what to find the best ways of testing compounds is also very important, and for the benefits of patients. And so these are, I think, the things that I would put into the focus, so to improving clinical trials, improving the patient involvement in diagnosis, and maybe finding new blood-based tests.
Thank you so far, Lutz. Eva Holmerová, she's very well known in the conference because she's the chair of Alzheimer Europe. Welcome to this table discussion. She's also one of the founders of the Czech Alzheimer Society and was for many years its chair. But Eva has on one side also a scientific background as physician and consultant in geriatric medicine. She's the director of the Center of Gerontology in Prague. But she has also interest as a family member because you told me that your mother and her partner both living with dementia, so you have both perspectives. If you look to the past and in the future, what have been achieved in your point of view, and where do we have to go in the field of research?
Thank you very much for addressing me. I'm not sure if the microphone works. Yes, it does. You spoke about the past, and I think that it's important to take the past also in consideration, because as far as we know, much research was performed already or only very late in 19th century and in very early decades of the 20th century. And first cases of dementia were described by Arnold Pick, and also, of course, Alois Alzheimer and Oskar Fischer. And it is really very interesting to look into these old papers and old publications, at their attitude. And yes, I wanted to compare the work of Oskar Fischer and Alois Alzheimer. Their publication was published in, and we have just the jubilee, because it is 110 years since, in 1907. Yeah? And I have to admit that, yes, Oskar Fischer has 12 patients with already described senile dementia, because at the time already was much spoken about senile dementia. It was quite common word within the research community. And I also looked at the paper of Alois Alzheimer and the history of Alois Alzheimer, and I think that really it was something unique that he did, because he followed his famous patient August Taddy from the not beginning, but from the development of her disease until her death. And despite he was not already working at the clinic, he asked to participate in her autopsy and describe his famous pathological picture. And I think that, this work of Alzheimer, this attitude, is is still very unique. And maybe during decades, we have forgotten that it is also necessary to look very carefully at the development of the clinical picture in individuals and to understand the complexity of the disease. Because, yes, there are very many causes of dementia, very many causes of cognitive disorders in general, and of course a diversity of people and factors that are contributing to the clinical picture of the disease, etc., including psychosocial factors, including biological factors, comorbidities, and so on. So I think that the complexity is the important factor that is necessary to address and to provide a detailed picture. And I think that now, with the use of modern technologies, we have the unique opportunity to pool the data and to better understand the diversity of dementia and of Alzheimer's disease. So I think this is the future. And I think that, yes, we have had the possibility to follow it also already in many projects because they are dealing somehow with the complexity of the picture.
Thank you, Eva. If you think about the 90s or the early 20th century, it's a long time since the first research has been done.
If I may add something, yes, it is long time, but it is not that long time like other diseases that were more frequent. So diseases or have been described since centuries already. Not so with dementia. It is only one century history. So I think that we have to substitute this complex picture, and we have the unique opportunities by collecting data, big data, using modern technologies, and so on. Because yes, unfortunately, we do not have centuries to describe the disease.
Okay, thank you. So our next speaker I would like to introduce to you is Pierre Meulien. I hope the name, I asked him before, but I'm not sure with the French name. Welcome to this table discussion. He is Executive Director of the Innovative Medicines Initiative. That's a public-private partnership, and you are based in Brussels, I think. And to find a new therapy is the hope of many patients. We heard it from Helen, but also from Lutz. Can you explain for us what is the role of the IMI Institute? Maybe not everybody of us know the Innovative Medicine Initiative, and what's the role of it in the field of research?
Well, thank you very much for inviting me, and thank you, Jean, for your support and interest in what the Innovative Medicines Initiative is doing. We are, as you say, a public-private partnership, and it is actually representing a long-term commitment, both from the public side through the European Commission and the private side through the European Federation of Pharmaceutical Industries and their associations, so the European pharmaceutical sector. And this is a very unusual partnership and a very long-term one. So it has gone through over 2 framework programs in the European Commission, which means 14 years of solid commitment from both public and private partners, 5 billion euro of commitment, financial commitment. And this is the most significant public-private partnership in the world to try and tackle some of these real challenges for human health. So it's not for it is a funding mechanism, and it's a funding mechanism that may not be suitable for everyone or everything. But dementia research is absolutely in the sweet spot of IMI, and the reasons are the following. First of all, the complexity of the disease has already been mentioned several times, and the risk that entails for private investment to actually come up with solutions for this disease, the risk of failure, and the pharmaceutical companies well know the history of failure in this that was well described before the coffee break in this area. The risk is so high that we need to find a way to balance that risk, to share that risk. And the pharmaceutical companies, through IMI, are in fact asked to do several things. First of all is to share their data and work collaboratively amongst themselves, which is quite new for the pharma sector in some ways, quite unusual. And the other thing is to share everything with the public sector too. And when we launch proposals, there is a competitive part, which is public sector. People can come in and compete for a chance to sit down and build a public-private consortium on a particular area with the predefined industrial partners. And we can do things at scale that some of these challenges require that almost no one else can do. So an average project of IMI is around 30 million euro over 4 years. And these challenges demand scale. They demand scale if one wants to, for example, look at new clinical trial paradigms, look at new ways of bringing in early diagnostics, look at new ways of engaging with people who are living with dementia and who can co-create and co-develop research partnerships with us in a multi-stakeholder platform. And this is what we do. We not only do it for dementia, we do it for many other things, but dementia is a big part of our portfolio. We have 9 or 10 projects ongoing in neurodegeneration in general, an investment of around 250 million euro, so it is at scale. And we hope that this can really impact both the way our industry partners can hopefully develop new treatments. They're willing to work collaboratively together after realizing that the problem is bigger than any one company, bigger than any one research group, bigger than any one entity, and we need to work in a much more collaborative manner. So that's the model. I'm sure we'll have a chance to chat a little bit more about what's going to happen in the future. But we have a big investment there. We hope that we can impact both the ability for industry to bring new interventions for dementia, and also on the public side, of course, that huge need both on the economic, medical, and social need that we've discussed a lot about over the last few days.
Thank you. That was really interesting, especially what you have said about the sharing of data. I think maybe we can come back if we talk about the future, or maybe even about the barriers in research. But first of all, I would like to give everybody a chance for a first statement, and I come to Myrra Vernooij-Dassen. She's also very well known because she's speaker for many years at the Alzheimer Europe Conferences. She's a medical sociologist, and very important, she's chair of the INTERDEM group. INTERDEM is always included in the conference, and you have your meetings here. And you're also a member of the scientific advisory board of the joint program of neurodegenerative diseases. So Myrra, if I ask you, research is not only done in the field of medical treatment. INTERDEM is a group of researchers, as well as the GPND program covers much more fields. What other fields are addressed in scientific research, or should be addressed in scientific research, in your opinion?
Thank you very much for the invitation and for this question. I think when we speak about dementia research, it's often reduced to biomedical research, and I think that's a pity, because psychosocial research offers a big chance for improving the life of people with dementia and the families immediately, and it's also a chance which we underused. For instance, the concept social health give us the opportunity to influence the social life of the person with dementia. And the persons with dementia, if you talk about suffering, they suffer from the disease, but not necessarily. But many of them suffer from being socially excluded. And there are very simple things that we can do even without research immediately here and now, and that prevent people with dementia to be excluded and to be treated as special individuals. And it's not only that family members can make mistakes regarding to that, but also professionals, and they do. If you go to giving the diagnosis, a study has been done on how persons with dementia perceive to receive the diagnosis, and there are positive results, meaning that the people are not shocked when they had when they expected that they had a disease, but many people complained that they felt disengaged and disempowered, and the fear for future exclusion. So suffering is also caused by social interactions. On the other hand, we have a lot of powerful psychosocial interventions in which we proved that the quality of life of people with dementia and their family members can really be improved. So the evidence is already here. It should be implemented, and it's an underused chance to improve the life of people with dementia. I also would like to make a plea for a connection between biomedical and psychosocial research, especially when you use new theories like the cognitive brain theory, that there might be. I asked Wiesje van der Vlier whether it was already possible to see which capacities were still left. That's for a specific patient, it's still difficult or impossible at this moment, but it will come. But from that, if you depart from the idea that there is a cognitive reserve, so that and we also know that there are a lot of people with dementia diagnosed, and there a lot of people prove it by being here and the way they interact with us. That they have very few symptoms. So it's not always necessary that if you have the diagnosis that you will have all these symptoms. So these are openings we don't use enough, and I would really like to make a plea for more research in that field.
Thank you. That was clearly said. I come now to our next speaker, and it's very easy for me to pronounce your name because you are born in Germany, Andreas Holtel. Even if you now don't work in Germany, but you work for the European Commission, you are a senior scientific and policy officer in the European Commission, and with more than 15 years experience in the health research. So I'd like to ask you, concerning the European Commission, what are the main fields the Commission addresses in their programs? You have a lot of programs currently, and how do you see the role of the European Commission and maybe oncoming programs in the future?
Yeah, thank you very much for giving us this opportunity to sort of interact with you directly. I think it's a beautiful occasion that we come a bit out from this very distant program management that we tend to do there in the European framework program execution there, so to speak. And I think it's important in order to respond to your question to priorities, it's a bit important to see that funding mode in which we are working there. I think we have these framework programs, and we had a sequence of them. We had always some sort of special focus on a major issue that was addressed by the previous framework programs. And the last one, the current one, Horizon 2020, is on innovation, so a lot of focus on industry, innovation and products. I think the forthcoming one, now there is a upcoming discussion that we need more emphasis on citizens and tangible results and all these issues like patients and social setups there. I think is certainly in the remit of what should be looked at for the future planning. Coming back to the current foci that we used to have, so we had in the past framework program still calls tailored to certain identified gap areas, and we did special calls. We had also this, still have and will have the joint programming for the neurodegenerative diseases. So I think we have major flagship activities where we take care of that area. There has been continuously major funding for Alzheimer disease, for dementia, for neurodegenerative disease in general. So it's about, for Alzheimer, 50 million per year, which is quite a significant amount. I think what is important to understand, I heard so many research priorities that you rightly voiced. It was very interesting for us to listen to understand that we have sort of progressed a bit from targeted, tailored calls for certain priorities to have a more cross-cutting approach that you have seen in the Horizon 2020 program already, that we have something on large cohort studies or on regulatory issues to be addressed. So I think there is a different mode that we were asked not to focus specifically on communities. So it goes a bit more back to your community, and I can see that the Alzheimer community is a very solid and well-established and organized community with your 27 conferences there. So thank you for doing that work that is also probably facilitated through past EU support. But I think it's key really to communicate between yourself and with us at the sort of important issues, like also on the need for adaptive clinical trials or the need for randomized large-scale trials that would add more value to what so far you have found with observational studies, that these things get communicated in a structured and solid way, and that basically you find your ways into our funding activities that go via different sources. You have IMI for more industry-relevant activities. For them, markers is very important. You have us maybe still for clinical studies support as such. So I think it's important to know that in principle, the whole scope, also psychosocial context, it is all possible in our program, but we are not in our calls, we are only still managing a third of the funding that the framework program distributes, goes really via our core commission in-house services there. So I think it's important to understand that you need to address and to look into all directions of funding sources, and then try to sometimes ex post and ex ante trigger applications, and where you see a need to have more research activities funded there to sort of trigger activities from the community to address wherever these funding options turn up there. It was a bit long, sorry, but
Thank you for the overview about the work of the Commission. I think not everybody knows so much about it. Last but not least, I come to Winfried Teschauer, and I have started with Helen as a person with dementia, and I address you now as a representative of a family caregiver association, because Winfried is a member of the board of the German Alzheimer Association and the Bavarian Alzheimer Association, because he has already had 3 people with dementia in his family, but also he has a scientific background. He's a scientific head of the Ingenium Foundation, which is, of course, in Bavaria. Not of course, but in this case. And as a representative of a family caregiver association, what are the fields of research that are necessary from your point of view?
Yes, thank you, Sabine, for a nice introduction. Of course, most important institutions are in Bavaria. And, yeah. Okay. I want to bring some different point of view into this discussion. Care today and cure tomorrow is this year's Congress motto, but and we have heard some very encouraging results from the talks during these 3 days. Nevertheless, there is no defined time scale for any time horizon when tomorrow will be. So we should not lose sight to the difficulties emerging by taking care for people with dementia while hoping for the cure. In Germany, I think there's about 99% of the money spent for research in dementia given to basic research in neurobiology, pharmacological interventions, and also understanding the pathological mechanisms of neurodegeneration. So please do not get me wrong. I myself am a neurobiologist and a biochemist, and I'm very impressed about this field. But on the other hand, I'm also a gerontologist. And when taking care for my mother, who died from Alzheimer's disease some years ago, I learned a lot about the problems next of kin have to solve. To realize that non-pharmacological interventions had not been used frequently in nursing homes, for example, and are now hardly used in hospitals. Nursing and caring for people with dementia in hospitals is a very important issue we talked about yesterday. We should not miss. I had the opportunity to work with students in nursing sciences for 1 year, and I had to notice that dementia, again, was taught by my colleagues in a very mechanistic and functional way. But what about the people with dementia, what about the world people with dementia are living in, as far as we know? I was very impressed about the words Chris Howard said on the first evening, in the first talk. He said, I'm living with dementia, but I'm not dying from it. It's a very important sentence. And how should we implement well-designed education programs for nurses and physicians? I'm convinced that one important component to achieve this aim is to strengthen the research activities on dementia in nursing and caring, and also to improve evidence which interventions are helpful and which are not. And so please allow me to stress another item which seems to be very important to me. Hospital just showed in the last session, convincing data in the plenary session, that the prevalence of dementia in Caucasian population is decreasing within decades about 25 to 45%. He also presented some data showing that possibly about 1/3 of the diseases could be avoided by controlling individual risk factors, mainly physical inactivity and low education levels. From my point of view, it would be a very important point to strengthen also this area of research. There is obviously evidence that single lifestyle risk factors have an influence on prevalence and perhaps also on incidence in dementia. So let us have a closer look to this issue. Thank you very much.
Thank you for your additional points, Winfried. If I open now the discussion for everybody, first of all here on the stage, but later on also on the ground, So if you have already any question in mind, keep it. I will ask you in a few minutes to ask questions yourself to the people on the stage. But I would like to come back to cooperation and competition. So we had already heard a potpourri of different themes, and I can imagine that also the different kinds of research, is psychological research, is it medical treatment research, is it maybe practical research in a hospital. So we have so many themes and we have limited funding at all. Where do you see the barriers that brings us or hinders us to bring up research, and do we need more international cooperation? And what do you think about the aspect of data sharing, for instance? I think that's quite an interesting point, because if everybody keeps this data and starts again to evaluate new data, maybe this work is already done. So that can be a barrier to go on with research. So what do you think about barriers, but maybe also about chances we have with corporations, like in your case you showed us, or also maybe between researchers, international research? Yes, please. I see you have the mic. Pierre, do you want to?
Well, maybe I'll start. And I think it is one of the gaps that we have, or the things that we should be doing a lot better than we are. And I think that IMI can play a role in that. What we have not done a good job of is to join up dots. It's the arena, even around in our own particular area of activity in neurodegeneration, is very fragmented. It's very fragmented within Europe, but it's also not connected enough with what's happening globally. And so I think we need to have either specific programs or specific methodologies and mechanisms to do that better. Then I know that we get in immediately to this data sharing, cross-institutional, cross-jurisdiction piece, which I think will evolve. I think patient groups have a huge role to play there in pushing the boundaries of, because I know that they have a huge interest that data is shared more easily across some of these boundaries. So I think that's where the patient voice can be really, really strong going forward. But I think we as funders have also a responsibility to defragment this area a little bit more.
But if you speak about special programs, whom do you think should coordinate it? Because otherwise we have maybe, again, one program here and another one there.
Well,
do you have a special idea?
There's no magic bullet, right? But I mean, I think among funders and countries, we have to find ways of coordinating. We know, we already do a little bit of this in other areas. For example, antimicrobial resistance, which is another huge hot topic, where we coordinate what we do with some of the big groups in the US and elsewhere. And so this can be done, and it's just a question of taking the lead. I think in Europe, the European Commission takes the lead on a number of these things. I think that should continue. But also other funders and governments can play a role.
Lutz, you want to add something?
I would comment from a different angle. I think data sharing is being pursued, and it has advanced a lot in dementia research. All the large cohorts which exist are now being sort of trying to merge their data. But this is, I think, not towards innovation. I mean, research is always on innovation and finding something new. And when you use old data, you always have the data as they are. You can find out why things maybe have not worked and may use them to start maybe hypotheses or so. But to create really new knowledge, I think requires a lot of innovative things and new data. And so this cheap solution of using and sharing data and trying to make the best of it is okay, but I think it needs more money and it needs more innovative things as well. And the money is a problem, yeah? In comparison to other research disease areas like cancer or HIV or so, when we're trying to talk within who is the best among of us and what should we do within that frame of limited money, then that's one thing. But I think it needs to go beyond, and we need more money in that area.
Something?
Yes. If you look for new results and new data and new ways to address this problem, it can be looking for a different angle. And since dementia is a multifactorial disease, we might make a big jump forward by putting together our knowledge, and I mean putting together the results of several scientific disciplines we have. And that is something we are only in the beginning to do, and I am fully aware of all barriers that are there. But if you are explaining, so we have Alzheimer, we have dementia, and it's very complicated, and a lot of scientific disciplines are involved. And then people ask, are you collaborating closely together to solve the problem, to make the puzzle? The answer is definitely no. And I think we can really, we make little steps together, but we don't make the full picture. And I think that might be a great chance for us to improve.
do not agree completely, but the applause is yours, Myrra. But Andreas, you want to...
No, I think, it's obviously, it's clear that we want innovation, but I think nowadays people, and we all think, and I think rightly so, that we can gain a lot of new insight by using old data, by putting them together. So there's all this screening of genetics data where you find new targets, and I think there is a lot to be gained there, and it is an issue that has really been recognized. So I think it is for the community, like the Alzheimer research community, I think you should join the wave there. Yeah, that is something where we have communities like traumatic brain injury. They are actively testing this data exchange and issues there, and personal data safety. And I think one needs pilots, one needs communities that are happy to embark on such a thing. And I think it will be of great value also for the respective communities. This is one of these examples where I think one should watch out what is ongoing there and then come in with your community and join. There's also the Human Brain Project. I mean, if you talk about collecting data, they are sort of trying to have additional projects there with communities that deposit their data there. There is imaging infrastructure that look for data. So all of these sort of activities that are ongoing, I think, should be recognized, should be taken into account, and should be utilized. And for this, you need coordination also within the community. And I think with this joint programming, activity that is really a longer-term thing where you have research agenda and identify gaps, you have a lot of possibilities to actively play a role in this game with different players in that landscape of dementia research in Europe. No?
I would like to give the word to Eva, but first I would like to ask, is there already any question in the audience? Okay, you are the next. So first I give the mic to Eva, and then you can ask your question.
Yes, thank you for, I would agree with you all, because I think that we need old data and new data as well. New, more detailed data, because the God is in the detail, somebody said already, Warburg was it. So I think, yes, we need it, and we need better collaboration across disciplines, because I'm really fascinated somehow how very short clinical trials still are compared to the trajectory of disease, and how very rough measures are used in them. It is really surprising when in the situation when we have such a massive psychosocial research on outcome measures, etc., etc. So I think that the interdisciplinary collaboration is crucial and quite necessary.
So you agree with Myrra about the cooperation? Yes. There's one question here in the first row, I think. And John is the next.
Hi, I'm Carol from Scotland again. I don't want to cause any controversy, but I go to a lot of meetings, and again, sit and listen to you, it feels like it's just reinventing the wheel again. It's always very, very similar. Now, with somebody with dementia, I'm not getting a lot of hope sitting here, because it is always, it's been tried, it's been done, and now you are trying, doing it again, if that makes sense to yes.
So you have got a skeptical response. Maybe before I open the floor, I collect another question. Thank you for this question first. And Jean, maybe you add another question.
Yeah. So my name is Jean-Georges, the Executive Director of Alzheimer Europe, and it's fantastic to get all this interesting feedback. I actually had a slightly different take to that of Carol, because I have to say I'm very encouraged that I feel that we're doing things differently, and I really get the feeling that we are hopefully doing things better, and there's more coordination and more collaboration and more willingness to work across barriers and across countries and across disciplines than we had in the past. So I'm feeling quite encouraged by some of the kind of collaboration, especially also at the European level. But if you're looking at Europe, it's symbolic that we're here in Berlin, because Berlin was really the symbol of a kind of divided Europe. And if I look at the dementia research landscape in Europe, it is still very much a divided continent where most of the best researchers are probably in the Western and Northern European countries, and we have a lot less capacity in some of the Eastern or Central European countries or even Southeastern European countries. And I'm just wondering what we can do to make sure that people with dementia will be able to participate in clinical trials also in those countries, that we make sure that researchers are really going to be skilled up, and that we also give better and more research opportunities for especially young researchers in those areas. So that would be one of my suggestions for better European collaboration as well.
I would like next give the word to Helen. She wants to answer maybe to one of the questions, but maybe after it we can maybe look where we have good examples, because I think, Lutz, you did not agree completely with that statement of Myrra. Maybe you have a good example for cooperation, but first of all, Helen.
Yeah, well, I have a mic, thank you. I just want to refer back to Carol's question. I suppose the way I look at it for myself as who's 5 years diagnosed and came in through psychosocial intervention, and that's why I really believe in this research and that we should be more involved in this research, is that 5 years ago there were very few people involved with the illness. And look, here we are today, 38 or 9 of us at this conference. And I think one of the greatest things that I've got at the discussion so far, I have to be honest with you, is the sharing of information. Because that is something that has been talked about over and over again, about a trial fails, and then, you know, why can't we share information? Why can't pharmaceutical companies share information? And it's really important that the sharing of information. So then the wheel will not be reinvented, Carol.
So you can look to the glass if it's half full or half empty,
50,
but your position is half full, I think. Thank you. Lutz, do you...
Well, of course, I mean, collaboration is a very important issue. And of course, but maybe it is my personal bias, but I think most of the collaborations being done in clinically patient-oriented dementia research are international collaborative, at least in the biomedical fields. Think of all the clinical trials, they are all multinationals. One of the most successful JPND-funded project was the BioMark-APD, a very large international collaborative effort on diagnostic issues. So I think this is being the mainstay of the developments, and it's of course of great benefit. Yeah? But innovation is always a surprise, and so coordination takes up a lot of efforts, manpower and money to coordinate, and it should be enough left for the innovative part itself. Yeah? So this is a delicate balance.
Yeah.
Do you think
can I respond? Well, the innovative part is not only in the biomedical. So we have to look to the innovative things everywhere, wherever we can find it.
So you agree now?
Yeah.
You want to add another question?
When I defended data exchange, I was not opposing having innovative ideas, and I think that was coming back to the original explanation I tried to give there, that I mean the new innovative ideas, they come now bottom up through our ERC grants, or they come through fellowships or whatever. We have not this sort of calls for new innovative ideas in a certain area anymore, and that's what I meant with coordination. They are there. We have seen beautiful screenings through this project that we can see from all the EU-funded activities there. You find beautiful ideas on modeling a disease progression or something. They come from ERC, so they are not they are not within our remit of coordinating from our side directly. So I think it's from the community to get in touch to assemble all these sort of ideas that come up and see what is useful for you. And that is the problem with this programming approach that I mentioned. And may I just give one other example, because you had this about the eastern part of Europe, less favored by our activities and less involved. I think we had a call recently on mental health, and it was for low middle income countries. It was actually more meant for developing countries, but we got a lot of proposals from Southeastern Europe partners. And so there is option there. Not many of them were on dementia. So this is where we cannot do anything because it's a cross-cutting thing. I just want to say, again, an example how from the community you have to steer, to have to encourage people to go into those options where there is something, for example, to go for the eastern part of Europe.
Lutz, if you are talking about the clinical research, do you think it's a different, what kind of research it is in concern of competition? So if you, because you're so focused on the clinical research, do you think maybe in the more basic research it's different?
Well, I think basic research has been received much more funding attention in a way. Yeah. So clinical research on translation of bench results into clinical practice is consuming a lot of resources, yeah, and it's a large effort, always a slower effort, yeah. But I think this is where the relevance for the patient comes out most easily. So I would argue to get this more into focus in a way.
Eva, it's your
Yes,
turn.
thank you. I would like to react to Jean's remark concerning Central and Eastern European countries. If we really have decided to tackle this problem, at least within Alzheimer Europe, and as you know, I'm from Prague now, currently as chair of Alzheimer Europe, and we have balanced and we have participation of many countries, nearly all, also from the Central and Eastern Europe in our Alzheimer Europe Association. Concerning the research, it is a really tricky thing, and I do not want to complain about it. It's just to give numbers, because there was also a Czech initiative how to tackle it within the research funding, because we know that all countries of Central and Eastern Europe have under 5% of funding from the age 2020, from the horizon 2020, whereas one single university in the United Kingdom is over that number, and whereas also countries out of the European Union, Europe, have more than this number. So I think, yes, it is nothing to complain. There must be something done also in these countries, but yes, it is a thing that should be tackled somehow, addressed.
Another kind of competition. So we have competition between the kind of research, and now we have competition between countries.
I don't think it is a competition. It's more about collaboration, more about involvement, also respecting maybe also all different culture in these countries, etc., etc. I think there are really very many questions to be addressed. So in no case it is about competition. It is about collaboration, of course. And I think we have proven it also in our monitor, in our dementia monitor that was presented in the European Parliament just recently. And it's quite clear that the Iron Curtain and wall, or the wall, still exists. Because there is a different level of care provision in former Central and Eastern European countries and Western countries. So again, it is nothing to complain of. It is something that we have to tackle.
Maybe not to complain, but also very sad if you think that's still a wall, maybe. But now Winfried.
Yeah, besides this discussion about sharing old data and new data and so on, Lutz, I want to ask you, you just mentioned clinical research. And again, is clinical research also nursing and caring research? Is this included? Yeah, I'm thinking about, for example, challenging behaviors in hospitals, which are a very big problem, and nobody really knows how to handle. Yeah? And so this should be included in research programs.
Do you answer directly?
Yeah, of course, care research in medical care, nursing care, and management of current knowledge and best practices. And so this is also part of what I would call clinical research. And of course, I mean, the question is, do we need new something, or how can we handle best what we already know and think would be nice to have? Yeah.
We don't know a lot about these items. Yes.
It's not implemented.
Yeah, of course.
The question of implementation of research is another very interesting discussion, but I'm not sure if we have time. But first of all, is there another question from the floor? Yes, please.
Hilary Doxford from the United Kingdom. I'm not sure that my question is relevant to this panel, but I think it has got a bearing on future research. Actually, I've got two questions. I'll do the first one because I can do it easily. It's about, I've forgotten the term, preclinical trials. If I ever come back to this planet, I want to come back as a mouse, because we all know that everything seems to work for mice and then doesn't translate into humans. And I was just thinking that why don't we actually get an understanding of these preclinical results in mice to try and understand why they work in mice models and then don't translate to humans? Because if you understood why it's working for mice and you could adapt that mouse model so that when you try it in humans, the mouse model's actually reflecting the human model, then a lot of money would not be wasted, because I think a lot of things working in mice then gets investment and it just doesn't work in humans and we don't understand why. And if you can change that mouse model to make it more reflective of the human, maybe we'd get some benefit. Have I?
Thank you, Hilary. I think it's very clear. Every time if we have some message in the media about success in mice models, people are very hopeful, I think. But I don't know. I'm not a person who can answer this question. Is maybe Pierre or Lutz, somebody?
Well, I'm not an expert on this, although in other fields, I know that you're quite right. The great successes in curing cancer in mice, or having a vaccine against influenza in mice and so on, and then the non-translatability of that to the human situation is a huge issue. And yet, it's very difficult to go straight into the human situation in many of these cases, because the underlying mechanisms of disease are so complex. So I think there's a lot of work going on out there on preclinical models. In fact, I don't know if Craig Ritchie was still in the audience, but he was talking earlier on about a whole workshop dedicated to model systems in dementia. And I think we need to have a lot of more understanding of what happens in those models in order to drive a path, a logical and scientifically valid path to then hopefully early enough assessments in human beings. Because that, I think, for dementia is the key. How do we get in safely but early in this condition?
Do you want to add something?
My time of working with mice is quite long ago, but of course, animal models for Alzheimer's disease have been one of the research priorities, let's say, in the first wave of the JPNT funding at some time. Yeah? But of course, it looks like Alzheimer's disease as a disease of the brain is so much different from what the models can produce altogether, that I'm not quite sure that this is sort of, how do you say in German, the king's road to the success. Yeah? Maybe the new things will come up. Yeah? Stem cell research, artificial brain systems on a cellular level. We don't know yet. It needs to be explored, but it is not clear that this will reflect the human situation. This is one of the challenges, I believe.
Thank you. Because we are coming slowly to an end, maybe I come back to the question of our roundtable discussion, looking to future research priorities. If I look to our discussion, I think we have a lot of priorities, and we cannot, it's really hard to define one priority. So, of course, the basic research on the mice models may have sense, maybe not in every case. We need the clinical research, we need the psychosocial research. But all this kind of research has a kind of, it's reasonable. So it's very difficult to set priorities. And we agreed in some background facts like a fragmented system, maybe for one person is the glass half full, for the next one is maybe a lot to be done, and the glass is half empty. We think about specific programs, but it's still a bit unclear who is the person who runs the programs, who gives the initiative. Is it always the European Commission? Who else can it be done? So it's very, I think one opinion that's a very complex disease, and it's also very complex to have the system with so many players. And we agree, I think, in cooperation, in data sharing, but there's also a possibility to improve the cooperation, as I see. And I think we all agree in your statement that we need more money. For what? That's easy to say and very easy to agree. I would like, maybe not everybody has an answer to it. Do you have any other ideas what we should do now? Also, as maybe I ask also as Alzheimer Europe, because I'm also board member of Alzheimer Europe, or whom can take over responsibility to go on? Do you have any idea which was not already discussed yet?
Can I just say one thing? And it's to do with the digital age that we're in. I think we need to embrace everything to do with digital on a much more grander scale than we're doing, because this can really, I think, transform not only the connectivity of the research area, if we were looking at big data and all the things we're doing there, but also on the individual person living with dementia. Because all that is going on, and I went to a session on digital technology this morning, everything that's going on in terms of monitoring behavior and function of people living with dementia, I think is going to be a huge piece in the outcome measurement that can be turned into patient-reported outcomes and so on, that can be incredibly useful in determining the quality and the impact of a particular intervention in this condition. And I think if we embrace that, and I'm coming back to the lady who talked about the social science and humanities piece, here I think the social scientists and humanities scholars have a huge role to play in being able to help design things in this area. And I would love to see many more social scientists and humanists involved in IMI projects, because I think that they would bring yet another dimension, a really important dimension to this multidisciplinary action that we're undertaking.
I think it's really timely to go and act and to do it, and this is especially because our separate fields have developed so well, but it's still fragmented, the total. So look at the total of the problem of dementia. What do we know? What are the gaps? And which disciplines are necessary? What should which discipline do to solve specific problems? But I really want to emphasize a conference like this is doing very well in that field, because now there are more both biomedical and psychosocial sessions, and we go to sessions of each other. And so this afternoon I learned a lot of the progress, and also what still has to be done, for instance, related to the cognitive reserve theory. So I think here we are also making a little step.
It's a very positive statement, and you can be happy because we will have a next conference next year, but this come later.
May I add a comment? I mean, when we look across the Atlantic, I mean, we are Alzheimer Europe here, but when we look across the Atlantic, I mean, there is this presidential act of making Alzheimer's disease treatable by the year 2025, which is a very interesting saying, yeah, but setting this type of target may be creating some momentum and some action. So I'm not quite sure that the US-American colleagues now in their present political system will have the resources and the focus to do that, but it has been quite a good initiative, I think. And there was the G8 summit here in London, UK. Yeah, we need similar things here, exactly.
Yeah. Sorry, this to have a cure by 2025 was a requirement of David Cameron. Yeah. It was a European. It was not across the ocean. It was a European.
That's great. And how much momentum has this gained here? I'm not quite sure. Yeah. But it may be the good idea came from here, but I think we should sort of get this into action from here, maybe. And the last thing is, again, the American colleagues in the American Alzheimer Association, they have created some sort of spots and focuses with their so-called professional interest areas at the side of their congresses to facilitate creativity for research and ideas. I think that's also a good idea that could be implemented in the focus of the Alzheimer Europe as well.
So we look over the ocean, but before we hear Agnes. You are the last question now.
Thank you. One of the things that I've been hearing from researchers is the consent forums for people with dementia to participate in research. And we heard in one of our sessions that a lady, it held her research up for 6 months. And it's the capacity. So universities make it ethically hard to gain a consent. Could we make the consent forms more accessible so that we, the people with dementia, can consent to become part of research projects, and that make it easier for people who are in nursing homes, because they don't lose capacity, they can still make consent, so that we can hear from all the voices, not just voices that you see at these conferences, but the silent voices. You know, that's what I would like. And I think that would be dead simple. If we sat round for the next half hour, we could make a simple research consent form, and there's an outcome for today's conference. Not a cure, but an outcome.
Agnes, that's a very interesting and very important point, and I know about a project in Germany. They work on this, especially on this theme, and maybe we can invite them for the next conference and to discuss it in an ethical forum maybe. But now for today, we have to come to an end. Time is running out, and I would like to ask one last question to Helen. Helen, do you have, after hearing this discussion, it's only one word, do you still have hope?
Well, I have hope. All I want to say to you is thank you all. For us, it's about for now until the famous 2025, which I'm sorry. We have to have a quality of life, and by involving us in research, and not in a tokenistic way, we know that we can help you change, and we know that we can help change and deliver how we are getting on with our lives, and how us and our families have quality of life. And that's all we're asking in the meantime, just to help us to see through that.
Thank you, Helen, and I'd like to thank all speakers, and I think the beginning of cooperation is to speak together, and that's what we have done today. Thank you very much.